There we go. Hello everyone, and back again, and today I am really pleased to introduce you to Yatna Ladwa, who is a podiatrist. You are a podiatrist, yes, podiatrist.
It's podiatrist.
Because when, I'm sure that one might have presumed that word used to exist, but I always remember you would go to, you'd go to someone just...
Chiropodist.
Thank you, chiropodist. And now it's changed over to podiatrist.
So back in 1991, they stopped the diploma as such of becoming a chiropodist, which was kind of what we'd call now like a college course, and it changed over to podiatry. I think the main reasons was because Canada and America, Australia, they all have podiatrists, and actually in those countries, we're actually doctors. In England, we're allied health professionals, so like physios and OTs, radiographers, we're all in that kind of umbrella term. So we do a degree in podiatric medicine, which is just for the feet. You learn about all the systems, the circulatory system, respiratory system, and how that's all related to the foot, because I think people forget that the whole body's connected. So, someone could have a stroke, and that is to do with your brain and then the circulation to your brain, but that has a knock-on effect to your feet as well, because the circulation can actually decrease or get worse going down to your foot. And our feet are the furthest away from our heart, so they can have problems which people don't connect to. So I think that's, this webinar I'll be touching on things and how they're connected, things that people didn't realize.
Yeah, absolutely. And funny enough, we had some questions that came in, because sometimes people send questions in to start with, especially if they can't come onto the webinar. And one of them is, why do I get cold feet? Now, I don't know, that's probably to do with the blood circulation, but I'm just thinking, because it's one of your extremities, isn't it? Mm-hmm. As you just mentioned.
So like I just said, our feet are the furthest away from our heart. And if we take the circulatory system, we have arteries, veins and capillaries. So let's take our arteries as our motorways, our veins as our A roads, and then our capillaries as the side roads. So as the blood travels down to our feet, it starts to trickle. So we go from the big arteries, from the motorway, down into the A roads and down into to our toes, which are side roads. So it's very, very small circulation getting in there. And what's happening is, these can be from a number of reasons. It's the dilation of the capillaries. So what's happening is the blood is not pumping to the toes as well. There's loads of conditions like Raynaud's, which is the most common, which affects your fingers as well. So people who get really white, ice cold
Raynaud's disease,
Raynaud's syndrome, or phenomena or syndrome. I actually suffer from cold-induced urticaria, which is an allergy to the cold. So it's not just my fingers and toes that are affected, it's the whole of my body. And what's happening is you get hives, which is like a nettle rash when you get stung by stinging nettles. But the reason people can get cold feet is mainly because of circulation, being out in cold weather for extreme periods of time. People like market stall holders, people who work outside, farming, warehouses. Also in warehouses you get concrete floors, so there's not enough insulation. So again, unless you've got like steel toe cap shoes on or nice thick bottom soles which can insulate and take some of that coldness away, it can really affect your feet. So you get cold feet, and some people are just born with cold feet.
Yeah. Right, so we've started at the end now by already answering one of the questions that somebody sent in. So let's wind back again.
Yeah.
We've established you're a podiatrist, and it's interesting that when I was younger, that the fact they were chiropodists and how it sort of changed. So Yatna, I know you work within the NHS. You also do private work, and also it'd be nice if you'd just like to explain the kind of work that you do, and also touch upon your charity, which I'm fascinated. I know we've mentioned it in our notes, but I'd love to share that with everyone as well.
So I qualified over 12 years ago, and I went straight into private practice. So where people would pay for their treatment. Currently, I'm working in the NHS and I specialise in long-term conditions. So the majority of my patients have conditions like diabetes, rheumatoid arthritis. They're currently having cancer care or recovering from cancer. I deal with a lot of foot wounds, diabetic foot wounds in particular, osteomyelitis, people with deformed feet. So which we'll touch on later, diabetes can change the shape of your foot, exposing certain areas on your foot, making them highly prone to pressure. So callus build up, breaking the skin open, and infection with people with diabetes, rheumatoid arthritis, systemic conditions. You're more likely to get an infection, and it can spread quicker because the circulation maybe isn't very good, and your chance of infection are very high. So I deal with a lot of patients, majority of patients who have foot wounds. Other things I do is nail surgery. So people with deformed toenails, ingrown toenails, the gorier the better for me. I love the gory ones that are really icky, and because it's a challenge, and I love my job. So I love giving that, someone coming in with a really bad ingrown toenail, normally the young men, because they've left it and picked it and tried all these ailments, and then you can give instant relief just by a procedure which takes about an hour. And then I also do routine work, so having people back for their annual checks, their diabetic foot checks, regular routine treatment for my high-risk patients, trying to keep them out of hospital, any admissions. Obviously with COVID, our main aim as podiatrists was to keep people from going to A&E, to reduce the burden on the NHS. So, making sure that my NHS patients know that we're their emergency foot line, their hotline. They've got a foot problem, you come to the podiatrist. And I always say this, you wouldn't go to the GP for a toothache, so why would you go to the GP for a foot problem? Go to a podiatrist, go to a dentist for your teeth.
That's very true.
And I think because podiatry is not very well known, the word, and people don't realise that that's what we do. And obviously we need more education out there on what podiatry is. We need a lot more exposure, which the College of Podiatry, the Royal College of Podiatry, should I say, we've been awarded Royal College status now by the Queen. We're doing a lot work to promote podiatry and get more podiatrists trained up.
So people go to the GP because it's on the NHS. They go to the dentist theoretically because most dentists, or there is a facility to go NHS. So it is possible to see a podiatrist on the NHS. Well, I know you work within the NHS, so it is possible to book something. How would you go about booking? Where would you find a podiatrist on the NHS? I know it sounds daft, but
you don't find, like dentists, it's not the same. Like with a dentist, you'd ring up and say, do you offer NHS treatment? And then you would pay the NHS bracket, whatever you need to pay, or it's free because you're on benefits or other things. When it comes to podiatry, unfortunately, that's not how it works. It would be, you would go to your GP with a problem, whatever it is, a corn, ingrown toenail, pain in your foot. They would then do a referral to your local podiatry team in your area. You would then wait, it would then be triaged by one of us podiatrists, and then you would be offered an appointment. Now, every NHS department will have a criteria, and unfortunately, it is that we are going the high risk to treat only high risk patients, because they're the people losing their toes, and unfortunately a lot of the low risk work we don't take on. So you would then get an appointment and potentially a one-off treatment depending on your medical status. So depending on what medication you take and what chronic condition you have and how it's going to relate to your foot. And we do checks like circulation checks, sensation checks. None of it's done by how much you earn, whether you've paid your national insurance or anything. It's all medically assessed.
Right.
And then obviously however your department runs, they will then advise you how often you need to be seen. Now, that's not every 6 weeks to have your toenails cut. That it's a review appointment where they'll get you back to just keep a check on you. And we always try to encourage that we work together. They're your feet. They're not my feet. So when you're at home, we're strongly encouraging. We're happy to show you and help you to how to maintain your feet at home, help you get your family and friends to help you. But then there are private services, like obviously I have my own private clinic, offer private services, and that's when you would then look to seeing someone privately. And that to get that type of care, you could go to Google, Yellow Pages, I think online, recommendation, and just making sure that they're HCPC registered. So that's the Healthcare Professions Council, which we're all, if you're going to practice as a podiatrist, you need to register. Just like a GP or a doctor would register under the GMC, a nurse under the NMC. So that's our personal registration and our insurance. But there's no harm in seeing someone privately in between NHS appointments. So if your NHS podiatrist says, right, we'll see you in 6 months, that doesn't mean you leave your foot care for 6 months and ignore it. It doesn't mean that you put your socks and shoes on and forget about them. I find a lot of patients with problems, chronic conditions, they kind of cut their feet off, as in they forget that they belong to them, and they suddenly become to me the podiatrist. I'm happy to help look after them, but we work together, because together we will save your feet from becoming really bad in the future. So I would always recommend, if you are under NHS podiatry and it is only every 6 months they see you, it's not because we can't see you, it's because actually we're not there to just cut your toenails. We're there to review you and monitor you and make sure that you know that we are there for you when you need us, and that we can provide you with an appointment sooner, not leave it a month, and your foot's deteriorated. So I would always recommend, if the NHS say we'll see you every 6 months for a review and we will top you up, take that hard skin down or take that corn out or cut your nails, invest in yourself and find a podiatrist that you feel comfortable with and see them interim. So like how I say to some of my patients, you see me every month if that's what you want, and then you get your free treatment with the NHS in the 3rd month. See it as a buy 2 and then you get 1 free. We work together, and normally you'll find private podiatrists will offer you the same level of treatment. NHS, so I treat everyone the same, even my private clients and my NHS clients, patients, but you get the time and obviously seen when you want to. So if you want an appointment this week, I can offer you one, but NHS you might be waiting 3 months.
Right. So to get an NHS appointment, you do actually have to go to the GP first.
Yes.
And get a referral. But
yes.
But I think you've already got over the message, which I agree. I mean, people do forget to do their feet, and we know how important it is, which we'll come to. But just to quickly rewind a bit, the other thing before we really leap properly into feet and healthcare is the mention that we were going to say of the charity.
Yes. So we in podiatry, in the podiatry world, I didn't set it up. Somebody called Belinda Longhurst and a team set up a charity called Forgotten Feet. The charity's been around for a few years now, and I'm hoping to set up the one in North London, so Barnet, because that's where I'm from, because there isn't one here, but we have one in Canning Town and in Walthamstow at the moment. I think there's some others being set up. And what the charity does is we offer free foot care to homeless people, and people who are in that position, who can't go to their GP, who aren't registered with a GP that can go via the NHS. Obviously people who don't know where they are from day to day or month to month. So I'm hoping to set that up in Barnet. I'm going to be doing that through the Salvation Army. I've got some contacts, so at the moment it's all the paperwork, getting everything sorted, finding a space. And with COVID, it's just made things a lot harder because you have to make sure there's checks and things like that. So it's made it a bit harder to set up, but I'm slowly in the process of doing that. And I've been wanting to do charity work for a very, very long time. And then when I heard about this, I thought this is perfect, a way to give back. what I was given. The NHS actually funded my degree at the time because it was funded by the NHS. It's now not. And it's working for the NHS is another way of me giving back what I was given, and also giving to people who are less fortunate. It doesn't, for me, it doesn't cost a thing. I just want to help people. And it's one way I know I can really give back to community and to people who are less fortunate than myself.
But I think that's great, and I would love to support you when you get going, because I think we all know, and what we're going to find out now is just how important it is to be able to keep on your feet. If you can't get up onto your feet, there's a real problem.
Yes.
So if we started, I think we say why feet are the foundation of our health. In fact, we say that. Well, I think we said that about the mouth as well. It's kind of from the top to the bottom, isn't it? I think everything in health is ever so important, full stop, because everything is kind of combined. But it would be interesting to say, and I think we've already touched on it, about the feet being the foundation of your health, because I know that you've said that when people come to you, you can do early detection of some really serious problems.
So I think the word foundation kind of is a good word to explain it or describe it. When we think of foundation, we think of the bottom and growing upwards. Our feet, I think the main thing that people forget, are going to take us to the end. You can't buy another pair of feet. You can't buy another toe.
They don't grow again.
I can only get you or find you a fake nail, which is fair. But apart from that, on a serious note, our feet take us from beginning to end. And I think people, again, like with the socks and shoes, cover them up and forget about them. You can go to the dentist once a year to get your teeth checked. So why can you not come and see a podiatrist to get your feet checked once a year? The things I can detect, and this is in people from a young age to an old age, podiatrists for everyone. There is no age limit, gender, anything. It's for everyone. I can detect athlete's foot. So a fungal infection on your skin, way before you notice that itch, those bubbles coming up on your foot, and I can get on top of that and advise you need a antifungal cream. And that, if you can get on top of that quickly, it stops it spreading to your nails, which then gives you a fungal nail. And, if you Google fungal nails, you can see how unsightly they can be. And I think once it gets down to the root, if you came to see me and I said, well, if you'd have come and seen me 6 months before, maybe we could have got on top of this. And I think it's hindsight that makes us think, I wish, or I shoulda, woulda, coulda, so much earlier.
So with fungal nails, just thinking about fungal nails, because funny enough, we've done quite a bit of work. We've done surveys and trials at Talk House with fungal nails. If you don't get on top of it, clearly it gets worse. Are you then prone to get back the issue again?
So once you've got it, so let's just say it's in the nail. If you don't get rid of it from the nail, it's there and it can spread to the other nails. So fungal bacteria is spore-like, so like crumbs. So it can be anywhere. So the longer you have it, the longer you're potentially spreading it. So once it gets down to the root, it's manifested fully into it. And then we're looking at removing the nail and allowing a new one growing. But what I've also found is that if you've got it on the skin and you've got it on the nail, the skin infects the nail infects the skin. You have a cycle going. And you need to break that cycle at some point, because you can spread it to other people, and you can infect the rest of your toes. And yes, you won't be able to get rid of it.
So yeah, no, not nice. And then I suppose that doesn't, I mean, and the problem of having it, apart from it being unsightly, because it's a bit...
It is, yeah, it's yellow and like a little beacon sometimes.
And presumably, is it sore? I don't know.
So you can get a fungal nail that doesn't thicken the nail. It's quite flat and it's just unsightly and you can see a yellow streak coming down. However, what a fungus does, it grabs onto the nail, it grabs onto the skin, and it manifests in between. And you'll see the nail get thicker underneath. So as the nails raises, because it's manifesting underneath, the nail raises up, which makes it thicker. But your shoe or your sock isn't raising with it. So you've got pressure from your shoe going down, the thickness of the nail, That's why it becomes painful, because it's become thicker and now you've got a pressure. So you'll come to see me and go, oh, my toe's really painful. And it's like, well, yes, it's got really thick. But that can also happen from damage. So dropping a heavy weight on your foot, kicking something, bad footwear, tight, bad footwear. Tight, bad footwear increases the temperature inside your shoe, your foot. And so athlete's foot, fungal bacteria thrives in warm, moist conditions inside your sock, inside your shoe. So if you've got a tight shoe, your foot hasn't got much room to move or breathe. So it creates moisture, it gets warm, and then it starts the production of fungal bacteria, and that will then thrive inside your shoes. That will live inside your shoes. So every time you put your shoe on, you're reinfecting. So I know we're going to talk later about general foot care health tips, but a good one is cleaning inside your shoes with a disinfectant wipe regularly, because then you're cleaning the bacteria. So that's why a fungal nail can be painful, and it's the colour and the pain that will trigger you to check your foot and come to see someone like me, or you'll go to your GP and go via the NHS and see someone.
So we've pretty gone from one thing to another, haven't we? Just whizzed on. No, Josh, don't apologise. I just wanted to make sure, because I know there's so much to cover, and it's making sure we, to look after it. So we can look at, as we've said, the foundation for your health and how you can identify things, and one of them particularly being diabetes. And did I make it up? And you said that you can detect heart problems in... So
when you come to see a private podiatrist or an NHS podiatrist, some of the checks that we do is your circulation first and foremost. One of the main reasons we do this is to see what kind of circulation you're having to your foot. Because let's just say I cut your nail, I'll cut the skin when I'm cutting your nail. If you've got poor circulation, or you're on things like warfarin, aspirin, that thins the blood, and it will mean you'll bleed a lot more. And so your blood doesn't clot so quickly. So we need to know about that. But things to look for in your feet early on. So when I'm doing the Doppler, so to check the circulation, sometimes I can diagnose atrial fibrillation, which is like a heart murmur, so you'll hear a da 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 da. It's like an irregular heartbeat, and people need medication for that. And so just by doing that one foot check, if you didn't have a heart problem, or an irregular heartbeat, or you might be like short of breath, things like that, we can say, oh, you've got you're an irregular heart, you've got a beat here. We'll write to your GP and say, would you be able to just do a blood test or to check for this? And 9 times out of 10, we can diagnose not a major heart condition, but something that the GP may not have picked up on. A bit more of a morbid thing is we can detect cancer from the foot, from certain things like, and I don't want people to go and start looking at their feet and any black line they find, all cancer, but there's a difference between a bruise and a certain kind of black marking on a toenail. And in the podiatry forums, there's so many people who are coming forward saying, with case studies saying, this patient came to me and I'm so happy they've just run me back to say that they've detected cancer early just by this one mark that you found on my toe.
And what's that mark look like? It's
a really black, kind of like a splinter line. I don't want to scare people. I don't want people to go and look at their toes and go, but it's normally like a black line that just comes underneath the cuticle. A podiatrist would be able to see it, and then they would say, I think you just need to go and get this checked out by your GP. We would write a in-depth letter saying why we think they should get checked out, but we don't want to scare people, but it's just proof that coming to see someone for your feet, that we can detect things through your foot, which is not on the same level as reflexology, can I just say. This is more medical. We don't look at your feet and touch certain parts and go, you've got a kidney problem. It's very, very different. But also for circulation, let's just say the colour of your foot. A cyanose foot, which looks purpley blue, that's an indication of poor circulation, but that could be the small capillary circulation to your foot, not the major arteries. And that's what we would check for. The sound of the artery and the blood coming to your foot is what we look for. Monophasic being poor circulation. So those types of patients I would want to be seeing regularly, every 2 to 3 months, to be checking, because people with poor circulation, it can reduce the skin strength, so making you more prone to cuts, your skin tearing, your skin becoming more fragile, so bruising much more. You know, you see elderly ladies and men who have on their shin, they have like those really dark bruises, and that's because their skin is very thin now, so it bruises much easily. And obviously their circulation, as we get older, just like roads, if they're not maintained, everything gets older. We don't, unless you have a bypass, we don't get new arteries and capillaries and veins. You know, we live like our feet. What we have, if we look after it, is till the end. So, and things do wear and tear. We get wear and tear.
But so it's good that you can find these things, because I mean, imagine lots of people, as we know, you know, there's the fine line between, are you being someone who's a hypochondriac?
Yes.
You know, but you're always going. But I'm sure that lots of people, and I don't want to sort of generalize, but a lot of people might go because their foot hurts, but they've got another problem, but they don't really want to know about it, so they don't go to the doctor. But it could be that you've diagnosed it, which is a great thing, and it's a gift, really.
So let's take diabetes, for instance. You come to see me and your foot, let's just say, is like this. Your toes are retracted, so bent, and you've got a high arch, and the ball of your foot's a bit more exposed. So as you can see, my hand is shaped like that, whereas you would want it similar to that. So I can just start talking to you and say, you don't suffer from diabetes, do you? And they can say, oh, no. Or we're in a conversation, you go to me, and let's just say you're mid-40s, early 50s, and you say to me, I go to the toilet so many times in the night, and I get really thirsty during the day. 2 indications of diabetes. So just from having a conversation and me looking at your foot, I look at a foot like this, and then you're telling me that you're getting thirsty a lot more, and you're getting up in the middle of the night to go to the toilet. 3 things for me that are screaming, this patient potentially has diabetes. So I could then go to say to them, I think you should book in with your GP and have a consultation, and just go and say this to them. I'll write a supporting letter, get a blood test done, fasting blood sugars, and you might just be diabetic. That's why you've got these problems. If they hadn't come to see me, how long before they'd put those 3 together? Or just the being thirsty or getting up in the middle of the night? Because some people might just say, that's just the way that I am, I've got a weak bladder. It might not be a weak bladder, it could be diabetes.
And this is type 2?
Type 2, yeah, type 2, typically middle age, 40 to 60, sorry. Normally overweight, lifestyle, to do with lifestyle. However, I get clients who look as fit as a fiddle, you know, slender. So, but predominantly, yes, overweight, bearing weight in their mid trunk, poor lifestyle, maybe poor diet, and that could lead to it. It's not about how much sugar you eat. And that's one of the myths that everyone says, oh, I've cut the cakes. I don't eat cakes. I don't drink fizzy drinks. Everything we put in our mouth, from tea, coffee, cake, pizza, chips, turns to sugar, glucose. So it's not about cutting down your cake or your fizzy drink. It's about having a healthy, balanced diet that keeps our blood sugars like this. When we eat cake, it suddenly spikes up and goes down. And having that constantly happen is what puts pressure on the pancreas to produce more insulin. And then that can lead to diabetes, which then means you need medication to help you. However, again, early detection of diabetes, you can go into remission of diabetes if you can get on top of it and actually have that diagnosis revoked and not be diabetic. If your GP was to say to you, you're pre-diabetic, that is your indication to change your lifestyle, do a bit more exercise, and within 6 months to a year, you can come into remission and actually not be pre-diabetic and or be diet controlled. I get a lot of patients who say to me, oh, but I take metformin, I only take one tablet. Oh, but I take diabetes tablets, that controls it. No, with everything, it's working together with your GP, medication to control your diabetes. It's not a case of taking a pill and that sorts it and you forget about it. You have to change your lifestyle. You have to start doing a bit more regular exercise, 3 times a week, 40 minutes, getting your heart rate a little bit higher, and a balanced diet. You can have the bad things that you enjoy, a bit of cake, but not every day. Not having bread with every single meal. Brown rices, pulses, a bit more vegetables, steering away from beige food, having a colourful plate, a rainbow plate. It will keep you fuller for longer and keep your blood sugars like this rather than spiking.
And I think that's what's so great about diabetes, with type 2 diabetes. You've got a really good chance, and the earlier you catch it, the better.
Yes.
To actually completely get rid of it.
Yes.
And it's not often that we say cure, but it's almost like the word you could cure it. Not everybody.
It's as if you can cure it if you detect it early enough and take onus of your condition, take it on board, educate yourself, and take steps to improve your lifestyle. And we're not asking you to make major changes, small changes slowly. I always say enjoy the process because you will do well at it, rather than make it a chore. We only live life once. We should enjoy it. So enjoy the foods you eat, enjoy the activity you do, try not to make it a chore. And there's loads of help out there for every aspect of your life to help you get.
And I think one of the other things, before we go on to sort of more common sort of foot problems and how we do it, I mean, I know we're looking at the extremes, but people don't realise that diabetes, how many people do lose their foot? And I think it's, and one doesn't say that to scare people, but it's a fact, and it's really, really important to know about.
So statistics show that a patient with diabetes who has an amputation, so we're talking a below the knee or above the knee amputation, their life expectancy reduces to 5 years.
Wow.
Before they either have another amputation or death.
Gosh.
So you can see, and obviously you have to think about the person as a whole, mental health as well, what that does to your mental health, your family. So again, coming back to early detection, taking onus of your conditions, making positive changes early on can help you greatly. I have patients that come to see me every month. They may have nothing for me to do to their foot, but they want someone professional to check their feet. Is my foot all right, Yatna, today? Absolutely. You're doing the right things. Keep putting your foot cream on. Keep your nails to this level. I'll trim them, tidy their feet up. But it's that, you don't have to see me every month, but it's patients like that who will keep their feet and will stop themselves from getting into red danger zones. And it's people who hide away from their problems, get a blister on their foot. Oh, it will heal in a few weeks. But no, because you haven't invested into your diagnosis of diabetes. What you'll know is as soon as you get a blister, you need to see someone. It's the blister that's going to lead to a wound, that's going to deteriorate, that can lead to bone infection, that ultimately leads to amputation. And the role of a podiatrist is to reduce the risk of amputation from lower limb extremities, and which could lead to death. That's what a podiatrist does. It's not toenail cutting and hard skin removal. No. That's not what I went to university to study. It's to help save lives.
No, and I think you've demonstrated it really well for us all to be frightened. Not frightened in a bad way, but to be.
Yeah, I don't want to scare people.
No, not at all. So moving on now to more common stuff as to how we can help. And I said we put the connection between foot health and chronic health conditions.
Yeah.
I suppose, how can we look after our feet generally? What should we be doing all the time? And especially if we've got a chronic health condition, what should we be looking out for specifically?
The easiest thing anyone can do with a chronic condition or without a chronic condition is look at your feet every day. Look at the bottom,
excuse me,
look at the top. And anything untoward that doesn't look normal or wasn't there the day before, then you should seek help. Are you okay?
I carry on choking. Now I'm wary of drinking water, thinking how much water do I drink, but probably not enough to worry about. But yeah.
So checking your feet. If you struggle, a key thing to do, if you struggle, you know, people who can't look at the bottom, who can't bend, get yourself a mirror, put it on the floor or up against a sofa and put your foot against it. I know I keep going back to diabetes, but there are other conditions like rheumatoid arthritis again, which can have the similar problems to diabetes because the foot changes there. Look in a mirror at your foot, and if you can see anything like yellow callus patches or a blister, you know, a rash, then you need to be either getting to your GP to get a referral or come and see someone privately again. But that's the main thing. In between your toes, looking in between your toes, like I was saying earlier about fungal infections, in between our toes, they're so tight together. So in between creates moisture and heat. If you're wearing bad footwear, which is tight or synthetic, so again, we all come from different backgrounds of what our affordability for footwear is. So, you know, I'm not saying you need to buy expensive shoes. Expensive shoes can actually cause you problems. It's about finding shoes that fit your foot. So look at the shape of your foot, look at the shape of the shoe. If the shoe is, let's just say, narrow, your foot is squeezing into that shape. Your shoe doesn't stretch and suddenly become the same shape as your foot. So your foot gets the blisters, the corns. So corns are areas of excessive pressure. So the ones that we get on our little toes, that's from badly fitting footwear. And anyone that wants to come and tell me it's not, I will say to you, it comes from pressure. One pair or some of your pairs of shoes are narrow or slightly narrow or have a seam that is rubbing. No shoe was made for you. It was made generically. So just because you're a 5 in one shoe shop doesn't mean you'll be a 5 in the other shoe shop. So you should be trying the shoes on, walking around the shoe shop, and you'll start to feel that burn on areas, and you'll know that shoe's slightly too tight for you or not the right shape for you. Unfortunately, you should put them back on the shelf and not pay for them, regardless of how much they are or how nice they are. So finding footwear that's a good shape. So one thing I want to say is wide fitting shoes. So when we find wide fitting shoes, the wide fitting is for the middle part. So where the joints are, let's just say the knuckles of the foot. It's not here. Okay. You can get a narrow shoe, which is wide here at the bottom. So your feet are still crumpling into this area. So I know they're beautiful and narrow and look so good with your suit. However, your feet are being crunched into the front. So you need to find something that's nice and rounded or square-like that fits your foot. So your feet sit nice and spread on the bottom of the shoe. And obviously, I always recommend a lace-up shoe or a buckle or a Velcro strap, and a thick-soled shoe with some cushioning, which gives you shock absorption. I was saying this to a patient earlier. You can get these barefoot running trainers or barefoot soled shoes. We are not cavemen anymore. Yes, we started off barefooted running on the pavements back in ye old times. However, we have developed as humans. Our feet cannot withstand the concrete the floors outside. You do need cushioning on your feet. Wearing next to nothing on your foot is not the best way forward. I remember when I did my second or third half marathon, the guy next to me went to my gym and he was wearing those barefoot running trainers which went in between his shoes, and I just thought, how are you going to run 13.1 miles? Yeah, he never passed me. God.
But that's interesting because you do see them.
Stone did though.
But you do see them promoted everywhere, don't you?
Yes.
But you're saying no, they're not.
No, I wouldn't be recommending those at all, especially people with chronic conditions, because people with rheumatoid arthritis, for instance, and I just want to quickly differentiate the difference between rheumatoid arthritis and osteoarthritis. I will regularly get people coming in saying, yes, I've got rheumatism. Yes, I've got rheumatoid arthritis. The first question I will ask you is, have you had a blood test by your GP that has proved or shown that you have the rheumatoid factor in your blood test? Oh no. Rheumatoid arthritis is a systemic condition which affects your organs, your joints, your muscles, everything in your body. If you have rheumatoid arthritis, you will know about it. It changes the shape of your foot. You will get what we call like swan-like fingers. So they go thinner at the joints because they get inflammation at the joints, and it's painful. And it's very different to osteo. Osteoarthritis occurs in our large joints, our hips, our knees, because they're weight-bearing joints. Everyone, even I'm 34 and I have mild arthritis in my joints because I do a lot of sport. So everyone can get osteoarthritis, and we will do as we get older because our joints will wear away. But rheumatoid arthritis is an inflammatory systemic condition which will be controlled with medication like methotrexate, DMARDs, which help with inflammation in those joints. So there is a big difference. And with rheumatoid arthritis, you can lose the fat pad on your foot. So you get migration. So the movement of the fat pad moves above, underneath the toe joints, which exposes the metatarsals. So the first thing the patient will say to me is, I feel like I'm walking on pebbles. So, when you cross the road and you've got the bobbly bits, it feels like that. And that's because they are literally walking on the bones because the fat pads move. And that, again, comes down to good footwear. Cushioned will help with that. The cushioning on the bottom of our trainers acts like fat pad. It's an extra extension of the sponginess on the bottom of our foot, which will help us going for longer. And you'll see when you're walking, you propulse, so you move more fluidly. When you wear really thin-soled shoes or trainers, you will start to feel that burn, that fatigue in your feet. And what will happen to you without realizing is your toes will start to do this because you're trying to move that pain to refer it. And over time, you'll start to claw. Again, with flip-flops and sandals that have no back or have the thong in between, very comfortable, very fashionable with your bikini and in the sun. But what you need to think of is these flip-flops and slip-on shoes. Your foot, the shoe is not attached to your foot. So your foot is going to do the work to keep that shoe on your foot. So your toes will grab to keep. And next time when you see anyone who's in this webinar, have a look at when you're walking outside. Look at people wearing Uggs. You will see how bad those are in winter. But also look at people wearing flip-flops or those sandals which have no back to them or no midfoot support. Okay, and you'll see their toes are slightly going like this because they're trying to keep hold of the shoe on their foot. And over time, your toes will change and they'll become like this.
Gosh.
So what then happens is you've actually caused yourself more problems in the future. You will start to get corns or hard skin on the tops of your toes because just remember, your shoe is not changing shape for your foot. So you've got a nice space in your shoe, but now your toes have crunched. Just trying to make sure the light, you can see my hands. So now the shoe's rubbing on top as you walk. So when you bend your toe, the skin tightens around this joint and becomes a lot more vulnerable. So when it starts rubbing, it's very thin. It's very, very thin from bone to skin, muscle tissue to skin, and it will wear down and you'll start to get these little nodules of hard skin, which people call corns, but they're not. Over time, they will develop into corns, which is areas of excessive pressure, the tops of your toes, also the tips of your toes, because you're not walking on the fat from the bottom of your toe, you're walking on the tip. So the tip's just going down and clawing as such, and then you start to get corns on the tips of your toes. And I'm telling you, the more corns you start getting, your feet will start to feel like they're burning. So wearing good proper footwear, and again, life's for living. I'm not saying wear trainers or granny old-fashioned shoes all the time. I'm saying wear the right footwear for the right time, for the right purpose. You're going for a walk, wear your trainers. If you're going for a swanky dinner date, okay, wear your narrow stilettos, because you're only wearing them for a few hours, but then you don't wear them. Don't walk to work in high-heeled boots and shoes and things. Wear your trainers to and from the office, in the office, and then when you go into that meeting, change into your fabulous Jimmy Choos, but then take them off.
Because I suppose what we're talking about really, isn't it, is making sure, because it happens over a gradual.
Yes.
So and then the older you get, the more you come off your feet, and it's then suddenly people realize I am really not on my feet because my feet hurt. I'm not walking, and then you go into a completely different ball game of health. One of the things that made me, and I know we've probably got still a few more things to talk about, but made me think about it. So, you're talking about the pads with rheumatoid arthritis, have the pads go. There's that thing, and you said it was like pebbles.
Yes.
There's that other thing, is it bursitis, I think it's called.
Bursitis.
Bursitis, that's it. And would somebody come to you with that?
Yes, they can do, because if you're getting bursitis, so the bursitis inflames, it might be that you need some offloading orthotics, so insoles made for you, and you'll find people with rheumatoid arthritis do need orthotics at some point of their life, whether it be extra cushioning or offloading, because the bursitis inflames or is in between your joints, and there's pressure being caused, and you'll find with rheumatoid arthritis you'll get bunions, and as it moves, the toes move inwards, you'll find, and if you're not changing your footwear, you're pushing the metatarsals together, so you're causing all these structures to swell, and also the impact on the nerves, and you can get Morton's neuroma in between the metatarsals, where you get a bundle of nerves that collect in between the bones, the small little bones, and then if you're wearing tight footwear, you're pressing on those nerves, which causes those sharp shooting pains. So treatment for that would be look at your footwear first and foremost, make sure it's not too narrow, and then we'd look into a dome to push those bones apart to allow the nerves to live freely. But some people, they can't get rid of it and then end up going on to have surgery, which can actually cause scar tissue, so not actually get rid of your pain, because then you've got pain from your scar tissue. Again, the same with bunions. You can have the surgery to straighten your toe, as we were talking about earlier, but then you're actually maybe left with a rigid toe which is straight. So sometimes the bunions, orthotics can help to get some mobilization into the first joint, which is much better sometimes than having surgery to straighten it out of aesthetic look.
Yeah.
But if you're getting pain in a bunion or pain in your foot, that should be an indication to come and see someone. But usually the problem, like you said before, is that the problem's been there for a while, but you only come when the pain comes. But the problem was there months before.
Yeah.
Corns, ingrowing toenails, hard skin do not occur overnight. Pain occurs overnight, but corns have normally been there for months to a year. It's only the pain that triggered you to get help.
Yeah.
So when you come and say to me, oh no, it only happened last week, it didn't. It's been there for a while. You've only come to know of it now.
Gosh,
so
the more you think about feet, God, there's so many things to go wrong, and they're just so important. And you're right, we all forget our feet, apart from in the summer when we might go and have a pedicure and
or go on holiday. But again, going for a pedicure, you're going to a beautician who's not medically trained. So I get a lot of women who come to me with ingrown toenails, and I can straight away see the ones that come who've been having shellac regularly, having pedicures regularly, just by the shape of their big toes. They cut down the size. Now, I've had one pedicure in my life, and I never even asked for it. I just just went with it. And she said to me, "Oh, you've got ingrown toenails. Let me sort them out." And I went, "No, I don't." She was good. She was ready to cut down the side to make them look nice and square. But what you're forgetting is you cut down the side, you make a gap. Your nail grows slower than skin moves. Your skin will occupy that space. Your nail will start to grow and grow into that skin. And over time, the sides will go from nails like this to nails like this, and they curve inwards. You need surgery to remove those, I'm afraid.
Gosh. I've got so many questions, and I don't think we've even finished. But so I think we've talked about maintaining good foot care. We've absolutely covered that. We've definitely got some questions.
Yep.
I can see that have come in, and the ones that I've carried on through. So let me just go through the ones that have just come in now. Please post your questions now if you want Yatna to answer them. Right, just a question, if it's not covered, any brand recommendations or websites for help re toes that are slightly twisted to the side and also raised joint nearest to the foot, second toe? That's quite specific, but
if the second toe is bent, that normally can indicate that you've got some arthritis in the big toe joint. So the second toe has actually started to take on some of the job role of the first toe. Again, deep footwear, making sure it's the right shape for your foot so that you're not squashing it, because the toe can then start to overlap and you don't want toes crushed. You can get toe separators, but what I will always say, and I know I keep going back to footwear, if you haven't got the right footwear for your foot shape, and then you start to go sticking things in between your toe, you've got two opposing forces, one trying to force your toes apart and one pushing them together. You're just going to come with calluses and more corns. So look at your footwear, deep footwear, so that your feet fit into it, and making sure they're nice and rounded. They don't have to be square. Look at your foot shape. A good way of doing that, stand on a cereal box, draw around your foot, cut it out, put it inside your shoes. If the sides start curling up, that's what's happening to your feet.
Yeah.
So your shoe is too small or not the right shape.
Would you recommend, and I know what the answer is, would you recommend a regular checkup with a podiatrist just as you would check up with a dentist, even if you don't have a chronic or problem with your feet?
Yes. You go to the dental hygienist to look at your pearly whites. What's wrong with getting your nice little toes out for me to see once a year?
Yeah, totally.
Yeah, we should invest in ourselves. We invest in everything we can see, but just always remember, you cannot get a new pair of feet. You can get new teeth. You can get new hair. You can't get another pair of feet. And once they start going wrong, or, it is hard to correct. And surgery, why would you? So
that's all painful. And it's all really painful, isn't it? That's the big thing.
What I say to people is put £2 away every week. And at the end of the year, come and see me. Or see someone.
Yeah. Now, there's a question here about bunions. So the question is, what's the best thing to do about a bunion? But I'm going to tie that into one that was sent to us.
Yep.
I've never had bunions before, but I've noticed there's one developing, and it happened from about my mid-50s. Is it going to get worse?
So bunions are hereditary or can be a condition, so like rheumatoid arthritis, for instance, or footwear related. They will only get worse if you wear bad footwear and force the bunion over. They may not get worse, but if they're hereditary, you're going to get them whether you like it or not. It's about making sure they don't get worse, okay? Right. And you can get ones where they go over, or what we call osteophytic changes, where you get bone buildup. So the big toe might not have gone over, but you might have a little bobble or a nobble of bone that occurs. But you don't need to do anything about a bunion unless you're getting joint pain, or if they're really aesthetically you don't like them. And if you really don't like them, you need to go to an orthopedic surgeon to be considered for surgery. If you're getting pain, yes, go and see a podiatrist or a biomechanics, MSK podiatrist, who potentially specialises in orthotics. And they can give you advice. And if you need orthotics because you need more function in that joint, they can prescribe you or do moulded insoles for you for that.
And I think also, I mean, something that I know, although not happened to myself, but other people who I know who've had the operation for bunions removal is not a walk in the park.
No.
It's not great. What I don't understand is how sometimes you hear that some people have both feet done at the. How do you have both feet done at the same time? Because you can't walk on them, can you?
No, from what I know, because obviously surgery is evolving, I think you have to be off your feet, and it's like 10 minutes every day, putting pressure through them or something like that, and it's like 3-month recovery. I don't know how people have both of them done, but I guess your lifestyle, if you can have that time off work, if you can work from home. But if it's painful, then I think sometimes I get people who just say, just do it. Like with ingrowing toenails, for instance, I'll pay the money, just do it. I need it done. It's so painful. Push comes to shove sometimes.
Definitely. Okay. So I'm just very aware of times. What's your best tip for walking in heels and not to be in agony?
Don't wear them.
That's not helpful, is it, if you want to wear them?
Practice in the mirror, your poker face. Look, if they're painful on the ball of your foot, it's because they're really high. And just remember, your balance comes up and all of your body weight. So let's just say you're overweight or carrying excessive weight. Your base of support goes from a nice wide base to a very small base of support. Your foot, the ball of your foot has to carry all of this weight. So it's going to be painful, but cushions on the bottom of your foot, but the best thing would be don't wear them, or only wear them for a few hours, and take some flat shoes in your handbag. Get a big handbag.
So some people like, I don't know, Victoria Beckham and all those people that are famous for wearing high heels all the time, and Sex and the City.
Yeah.
Are they suffering in agony inside?
Probably, or they've got used to it. Our feet do change over time. Victoria Beckham her feet have changed to the shape of her foot. I'm pretty sure I did read years ago that she does have bunions because of poor footwear. So just think of it. If you force your feet into an irregular shape, your foot will change. Muscles change.
So very quickly to wrap up, the lady that we spoke to first of all with the second toe, she says thank you very much, and she got them for wearing court shoes as part of her uniform.
Oh,
she now wears shoes as you recommended and says thank you.
Oh,
and we have got so much more to talk about. So I know that everyone will be pleased to know that Yatna has promised to come back, hopefully in October and January. October when we're going to talk about diabetes feet. And then also in January, when we're running a clinic on arthritis, that's rheumatoid and osteo. And you very kindly said you'll come and give us a webinar all about how to look after our feet with those issues.
Yeah.
That would be great. So thank you so much. And thank you, everyone.
It was lovely.
It's great. Thank you.
I hope you enjoyed it.
Thank you. Bye.
Bye.